Thank you all for joining us today for this session titled Every Symptom Tells a Story, Diagnosing and Treating ATTR Today, or Transthyretin Amyloidosis Today. My name is Ahmed Masri. I'm a cardiologist, and I practice at Oregon Health and Science University in Portland, Oregon. Let's see. All right, and so you can use your own technology. You have the Wi-Fi network and password here, and then you can scan the QR code in order to log in your attendance and ask questions as well. All right, so I already introduced myself, and we're privileged to have with us two amazing cardiologists who also focus on amyloidosis. Dr. Noel Dasgupta, who's an associate professor of clinical medicine at Indiana University School of Medicine, and Dr. Natasha Saraswat, who's an assistant professor of medicine and the director of the infiltrative cardiomyopathy program at the University of Chicago. So this is our agenda for the day. It's really, really busy, so we're going to try our best to stay on track. And we have to end at 3:15 because I have also to catch a flight. So, there is a personal reason there. And so Dr. Saraswat will kick us off with the hidden burden of TTR. Then we're going to go through the diagnostic journey and focus on therapies. And we'll have some discussion about how is this all fitting together? How can we do this, in our clinical practice? And so I'll turn it over to Dr. Saraswat, but I think we have one of our patients generously wanted to share some of her stories with you, so I think we're going to have a video here.
In both hands, which progressed to bilateral peripheral neuropathy in both feet and legs. I also had shortness of breath, inability to walk across the room, because the shortness of breath was so terrible. Those symptoms of the shortness of breath, the peripheral neuropathy, and the carpal tunnel just continued to get worse and worse and worse over time. And so I began to seek diagnoses to figure out why I was having all of these symptoms. I saw a neurologist who couldn't quite explain it, and we did lots of things like hand therapy, which of course did not work. The bilateral peripheral neuropathy, once again, the neurologist didn't know what to think of it. The shortness of breath was interpreted as me having pneumonia because there was fluid in my lungs, which was actually due to me being in heart failure. And I was finally diagnosed with heart failure due to the incredible edema that I was having in my legs and feet and my ability to walk across the room.
All right, so I'll turn it over to Dr. Saraswat, where we're gonna get some bits and pieces of this video throughout, and we're gonna tie it back to what we're learning about today.
Good afternoon, everyone. Natasha Saraswat, nice to be here, and thanks for asking me to talk today. Amyloidosis is something I do every day, all day long, and the story you just heard is something that we hear every day. Unfortunately, lots of patients will go through multiple different providers before they get a diagnosis, and while things are certainly improving, we still have a long ways to go. A lot of that is for exactly the reason you heard from her, and also just the myriad of manifestations that we see with amyloidosis. As we know in medicine today, everybody is super specialized, and there's not always one person who puts the pieces of the puzzle together and connects the dots here. So what we do know is that there are multiple, again, manifestations of amyloid. From a cardiac standpoint, often what we're seeing is heart failure. Certainly, that's a later manifestation, and we want to be able to catch these patients prior to them developing heart failure. Atrial fibrillation is extremely common, and if my patients have amyloid and don't have a diagnosis of atrial fibrillation, we're looking for it. We're screening them for atrial fibrillation. Other conduction abnormalities that patients end up needing pacemakers for bradyarrhythmias are also extremely common. There are a myriad of musculoskeletal abnormalities as well. Carpal tunnel syndrome, particularly when we know it's bilateral, is something that we hear often. And we are to the point that we are screening patients with bilateral carpal tunnel syndrome for this disease. lumbar spinal stenosis, and certainly spinal stenosis in other areas as well. Biceps tendon rupture, we actually call the Popeye sign. Shoulder pain, rotator cuff problems, other knee and hip pain. Certainly, I've had many amyloid patients that have gone for orthopedic surgery, even for their hips, and I tell the surgeon, take a small piece of tissue, let's look for amyloid deposition, and boy, do we find it. Trigger finger is extremely common. As you heard from the patient that just spoke, polyneuropathy, lots of times patients will say they feel this burning sensation in their hands and their feet like they're on fire, or patients will say as they walk, they feel like they're walking on clouds. Muscle weakness, and this is something that we're seeing progressively now that patients are living longer and longer. Certainly frailty, frequent falls, muscle weakness is something that we hear very commonly. Orthostatic hypotension, a lot of patients will present with dizziness, with changes in position, and intolerance to their normal neurohormonal blockade that they're given when somebody knows that they have heart failure. Diarrhea or constipation, a lot of patients will have alternating diarrhea, constipation, and certainly weight loss. Many patients, by the time they're diagnosed, especially if they're later in their diagnosis, have already lost 25, 30 pounds, a lot of muscle mass. And erectile dysfunction is something that we as cardiologists certainly are not always asking about, but that is something that's very common and can be a manifestation of the autonomic dysfunction associated with amyloid. So we were certainly taught in medical school that this was a zebra. What we know now is this is not a zebra and is actually not so rare. So when we talk about the different types of amyloid that affect the heart, we talk about AL amyloidosis, wild-type TTR, and hereditary TTR are the most common types. Now, certainly AL is still less common, and that is an estimate of thousands of cases in the US, followed by hereditary or variant transthyretin amyloid, which is in the 10,000s. And again, that's due to a variant in the DNA that encodes for the transthyretin protein that's made in the liver. Hereditary amyloidosis, we know of about 130 different mutations in the DNA that leads to hereditary amyloidosis. That can be very systemic, cause not only heart problems, but peripheral nervous system problems, polyneuropathy, autonomic dysfunction, the GI problems. And then certainly the most common one that we're seeing is the wild type. Wild type is where there is, in the transthyretin protein, we always tell patients is like a four-leaf clover. It's a tetramer that becomes unstable and falls apart into these one-leaf clovers that then bunch together and deposit in lots of places. So the wild type, we don't really understand why that four-leaf clover falls apart in the first place. We think probably more of a process of aging, but this is certainly an active area of research trying to understand. Tends to have a later onset. Over the age of 60 is a very common cause of heart failure with preserved ejection fraction and is associated with a lot of the musculoskeletal problems. The AL type, which, as we said, is among the three types, is a little bit more rare, is a bone marrow problem. The bone marrow creates these immunoglobulin light chains in plasma cells that can, again, be very systemic and deposit in lots of places throughout the body. So are we at the point that we can screen for this disease? I'm telling you that it's tough to pick up because there are so many different providers that are seeing patients for different manifestations, and yet it's not very rare. We have good treatments for it, and it's a disease that carries a lot of morbidity and mortality. Well, let's talk about what are the characteristics of a good screening test. Certainly high prevalence of the condition, an accurate and non-invasive test that's easily available, and something that we can do about it, an effective treatment available. And certainly, where we were 6 or 7 years ago, we had minimal treatment or no treatment for certain types of this disease, right? Very difficult to argue to screen for something when we didn't have something we could do about it. Now we're in a very different situation. So in 2019, there was an international working group led by Vitalis, and really they tried to propose who are the patients we should be screening. And what we're seeing are males over the age of 65 or females over the age of 70 that have heart failure or the presence of any of the red flag symptoms. So what are those red flags? Again, carpal tunnel, spinal stenosis, rotator cuff, biceps tendon, polyneuropathy, diarrhea, autonomic nervous system issues. So even the presence of any of those red flag symptoms, plus increased wall thickness on their echo in a male over 65 or a female over 70. So notice that it's heart failure or. You don't have to have heart failure. And again, we want to catch those patients before they develop heart failure. So when we talk about the different gene mutations, and you may have heard of the V122I or V142I, depending on which nomenclature we look at in the genetics world. The V122I is the most common variant of the TTR gene, and we see this in 4 to 5% of African Americans. It comes from sub-Saharan Africa, and a lot of that population as they've moved to the US. So again, 4 to 5% of African Americans have the gene. Not everybody who gets the gene variant certainly gets the disease. We're understanding the penetrance of that, which is probably around 30%. But the issue is, when we look at those patients who have this variant, just having the variant alone without truly having amyloidosis as a disease is a harbinger of a poor prognosis. So there was a retrospective study done in 2022 where they looked at 7,500 African American patients in a genetic study, and they followed them over years. And what they saw is that carriers, gene carriers, these are not even patients that have true clinical amyloid. They don't necessarily have heart failure or polyneuropathy. Their incidence of just developing heart failure separate from amyloid was significantly higher. The incidence of heart failure death, significantly higher. Cardiovascular death, significantly higher, and all-cause mortality. So, back to that question of, should we be thinking about screening for this disease? Just again, having a gene variant that causes such a difference in prognosis is very important. Okay, and what we know is that when we compare carriers to non-carriers, again, the risk of incident heart failure as patients get older is so much higher. So knowing that they have the gene variant alone, now we're developing prevention and other tools that we can use for these patients to, we want to be able to catch them earlier and notice that they have a greater incidence of death. So what are those other clinical presentations for TTR? So we've talked a lot about heart failure with preserved ejection fraction, and we look at the inpatient population, and even screening the HFpEF inpatient population, there are probably 10 to 15% of those patients that are hospitalized actually have amyloid. Arrhythmias, right? Should we be screening everybody with atrial fibrillation, for instance? Certainly if they have heart failure, those are patients we should be thinking about, do they have amyloid? Aortic stenosis, we know, is extremely common in this population. Low flow, low gradient aortic stenosis we see very commonly. Conduction disorders, again, those that require pacemakers, all of these should be kind of light bulbs that as you're seeing patients and you think, again, putting those pieces of the puzzle together. Hypertrophic cardiomyopathy, actually, a good 5% of patients who are labeled with HCM are actually probably amyloid. And certainly somebody may look at their echo and say, oh, their walls are thick, this is an HCM patient, and it's actually an amyloid patient. So kind of taking a step back and really thinking about the other comorbidities that the patient has can help you understand, do they have HCM, do they have amyloid? And this is where some of our imaging, right, cardiac MR and echo with strain can certainly help as well. And then when we think about neuropathy, so we as cardiologists, again, are not always asking about numbness and tingling in the joints, right? But it is very important, especially if you have somebody who has a gene variant, to recognize that the gene variant alone, even if they haven't had manifestations from the cardiac standpoint, they haven't had heart failure or anything, but they have some of those neuropathic symptoms, is one of those ways that we can tie everything together. So we can see neuropathy in gene variant patients, certainly in wild type as well, but we see carpal tunnel, spinal stenosis. We can see even regular polyneuropathy in these gene variant patients. So we think of different gene variants causing different phenotypes. The V122I, which we said is the most common in the United States, and in 4 or 5% of African Americans, was always thought to be more cardiomyopathic, right? It much more likely causes cardiac disease than neuropathic disease. But what we've realized is that it can also cause neuropathic disease, right? It's a spectrum. So very important that we're asking about these questions like numbness, burning, pain, and symptoms of autonomic dysfunction. And important to assess all of our patients as a whole, not just the cardiac manifestations, and that multidisciplinary nature of amyloid where we're working with our neurology colleagues, we're working with our GI colleagues, right? Yes, as a cardiologist, I can ask them about numbness, burning, and pain, but to be able to tease apart are there symptoms from spinal stenosis? Are there symptoms truly from amyloid deposition in the nerves? This is where I'm reaching for EMGs and calling my neurology colleagues for help. And then certainly, as we do a lot of genetic testing now and pick up different variants like the V122I mutation, very important that we're performing good genetic counseling. We're talking to these patients about risks and benefits of the genetic counseling and cascade testing. All these gene variants are autosomal dominant, meaning that each child or sibling could have a 50% chance of having the same gene variant. So our cardiology genetic counselor calls herself the amyloid genetic counselor because this is largely what we do, especially in Southside Chicago. We're building family trees. And we try to really, get patients, families to come to their appointments, be involved in the support groups, and understand the importance of genetic counseling. And that can really help them with understanding the risk for their child of developing the disease. Again, as we said, just having the gene variant alone can carry a lot prognostically, can help, families discuss within themselves. Nobody wants to talk about this over the Thanksgiving dinner table, but it is important to understand family history and, help provide support. And again, early identification of the gene variant helps us to monitor these patients, teach them about the disease so we get early intervention, and now we're developing prevention as well. With that, I'm going to hand it over to Noelle.
Hi, everybody. My name is Noelle Dasgupta. I'm a cardiologist in Indiana at Indiana University, and I'm very pleased to be speaking to you today. I think we have a patient video to start.
I was told I had heart failure and to actually go home and come back and see them in 6 months or 3 months, and that was unacceptable to me, so we found another provider who actually did do a biopsy, and that was the determining factor of my amyloidosis. In terms of diagnoses, when my cardiologist actually did the biopsy, there's a specific test that needs to be done to determine whether or not I have hereditary amyloidosis or light chain amyloidosis. Light chain will take you down a whole different pathway. And the test was not done completely, and in fact, they thought I had light chain, so I was sent to a hematologist to start a form of sort of cancer treatment. The hematologist took a closer look at my labs and said, no, you don't have AL. You have amyloidosis. There's no one in the area that we know of that can help you. So I had to go across the country to Boston, which was amazing because I was living in a big city. And the only thing that they did that was really different than what had been done before is I did a genetic test. And with the genetic testing, it was determined that I did have hereditary transthyretin amyloidosis, which distinguished me from having wild-type amyloidosis. So mine is a genetic mutation that I inherited both from my mother and my father.
Okay, I'm just going to review the diagnosis of amyloidosis. So as we've talked about, amyloidosis is often a systemic disease. So in addition to looking for cardiac manifestations, which we're going to go over, you want to look for other systemic manifestations like soft tissue manifestations or neuropathy, GI symptoms, autonomic dysfunction. And you want to tie that together with any cardiac disease. And just to review, heart failure with preserved ejection fraction is common in patients with amyloidosis. Usually the ejection fraction is preserved early in the disease. It's only until late in the disease that the ejection fraction sometimes becomes reduced. So it's estimated that there's a high percentage of patients who are walking around with heart failure with preserved ejection fraction that actually have amyloidosis. maybe about 13% or so, and I think Dr. Saraswat discussed some screening criteria. Another thing you want to look for is low voltage on their EKG. Now, amyloid proteins are inert and do not conduct electricity, so you'll often see low voltage on the EKG. The low voltage may not meet criteria for low voltage, but what you want to look for is a discrepancy between the voltage you see on the EKG and the wall thickness or mass you see on echo or MRI. Another thing that often occurs in patients with an infiltrative cardiomyopathy is unexplained persistent elevation of NT-proBNP or BNP and troponin. On echo, if you see a patient with LVH that is not explained by other causes like hypertension, you want to be thinking about things like amyloidosis. Patients with amyloidosis often present with advanced diastolic dysfunction. Of course, earlier in the disease, you may not see this, but if you see a patient with grade 2 or 3 diastolic dysfunction, that could be a sign that they may have amyloidosis in conjunction with other factors. Another thing that might be present is an abnormal strain pattern. Often patients with amyloidosis have preserved apical strain and reduced basal strain. You get an apical sparing pattern. On MRI, you may see diffuse subendocardial enhancement or increased extracellular volume. And another common thing in patients with amyloidosis, they often present with severe aortic stenosis, or more commonly, low flow, low gradient aortic stenosis is also very common. So I'm going to review the two types of amyloidosis that typically cause cardiac manifestations. And just to review for you all the nomenclature for amyloidosis, the first A stands for amyloid, and the second letter then stands for the precursor protein that misfolds and causes the amyloidosis. So the two forms of amyloidosis that cause cardiac amyloidosis in about 95% or more cases are light chain amyloidosis and then transthyretin amyloidosis. These are very different conditions. Light chain amyloidosis occurs because of a process where the bone marrow produces abnormal free light chains that can misfold and go to other organs and tissues. Whereas transthyretin amyloidosis is a condition where the liver makes a normal protein, transthyretin, that will misfold and go to other organs and tissues. The reason why it's important to know the difference between these is because the therapies are dramatically different. For light chain amyloidosis, it's typically treated with chemotherapy and stem cell transplant, and it's often a medical emergency. If patients are not diagnosed and have cardiac involvement and are not treated, they may die within 6 months. So it's very important to rule that out and then consider other causes of amyloidosis like transthyretin if you've ruled out AL. If you've diagnosed the patient with transthyretin amyloidosis, then as Dr. Saraswat said, it's very important to determine if it's hereditary or not. So this is the ACC algorithm for the diagnosis of amyloidosis, and it's pretty busy, but I'm going to kind of walk you through it. The first step is to look for clues from the history, EKG, and any other imaging. The next step is then to rule out light chain amyloidosis. How do you do that? You check serum-free light chains, and you check serum immunofixation and urine immunofixation. And you try to see if there's a presence of an abnormal monoclonal protein. Now, sometimes these values can be difficult to interpret because they're affected by renal function. So on the right, you'll see how the ratio may change if you have renal dysfunction. And the kappa light chain is less cleared when you have renal dysfunction, so that may be higher. If you find the patient has evidence of a monoclonal protein, then it's often appropriate to talk to a hematologist and biopsy, usually a bone marrow biopsy, and either a surrogate tissue biopsy or a cardiac biopsy is warranted. If you've ruled out transthyretin amyloidosis, then you can, or if you've ruled out AL amyloidosis, then you can make a diagnosis of transthyretin amyloidosis. And this can be done with biopsy or non-biopsy diagnosis using bone scintigraphy. And then, as we discussed, you can look for hereditary or wild type or age-related forms. So this is the first audience response question. Which lab should be ordered to evaluate for light chain amyloidosis? A, serum-free light chains and SPEP. B, SPEP, UPEP, and serum-free light chains. C, serum light chains, serum immunofixation, urine immunofixation. And D, urine protein electrophoresis, serum-free light chains, and prealbumin. Oh, I've got music. Okay, great. The majority of people realize that the diagnosis of AL is made by checking serum free light chain, serum immunofixation, and urine immunofixation. And it's really important to check all three of them because all three of them, if one of them is abnormal, that increases your likelihood of light chain amyloidosis. So I'm just going to, again, focus on how to rule out AL amyloidosis. It can be confusing for clinicians. And just to review, light chains are produced by the bone marrow. If you recall, antibody molecules have both heavy chains and light chains. The light chains that are made as part of the antibody molecule can either be kappa or lambda. So in light chain amyloidosis, you either get excessive kappa or lambda light chains. And again, these values can be affected by renal function. So that's one of the tests you want to do. Then you also want to check a serum immunofixation and a urine immunofixation. You don't want to just check an SPEP. What you want to do is actually check the immunofixation. Immunofixation is more sensitive and more specific to identify abnormal light chains, and it can identify smaller quantities by using antibodies to detect those. So it's very important to not just check an SPEP or UPEP, to actually go on and check the immunofixation. Okay, next question. Properly perform technetium-99 PYP to evaluate for transthyretin amyloidosis should include A, planar inspect imaging in patients without a monoprotein and normal serum-free light chains. B, planar imaging with heart to contralateral lung ratio. C, planar imaging in patients with a confirmed monoclonal protein. Or D, planar inspect imaging in patients with a monoclonal protein and elevated serum-free light chains. Okay, well, we have kind of a split here. So the first thing you want to do is rule out a monoclonal protein by ruling out for AL. So the correct answer would be planar inspect imaging in patients without a monoclonal protein and normal serum-free light chains. Okay, so once you've ruled out light chain amyloidosis, you can try to rule in transthyretin amyloidosis. You can either do this by doing a biopsy or a non-biopsy diagnosis. There was a study by Gilmore in 2016 in Circulation that found if you use bone scintigraphy, which is bone imaging, using tracers, technetium-99 PYP, DPD, or HMDP, could be used to diagnose transthyretin amyloidosis in patients without a monoclonal protein. And if you've ruled out AL, patients with grade 2 or 3 uptake of one of these tracers has a very high sensitivity and specificity to diagnose transthyretin amyloidosis. So when you do bone scintigraphy, quality control is very important. So you want to make sure the patient is appropriately educated about the test. And one of the key things is to not just do planar imaging, but to also do SPECT imaging to verify that the tracer is found not just in the blood pool, but also in the myocardium. On the picture on the right, you'll see that on the planar imaging, there's that dark area of the heart, which would be suggestive of uptake of the bone tracer. However, if you look to the right, you'll see that that tracer is limited to the blood pool and is not actually in the myocardium. So this could be a false positive if it was read just based on planar imaging only. So we want to look at the bone scintigraphy, look at both the planar and the SPECT imaging to confirm that there's tracer uptake. And what we do is we compare the tracer uptake in the heart to bone. So 0 is there's no uptake in the heart. And then once we see grade 2 uptake, the myocardial uptake is equal to the rib uptake, and grade 3, the myocardial uptake is greater than the rib uptake. So the expert consensus statement recommends that a positive test is grade 2 or 3 uptake at 2 or 3 hours. In very experienced centers, you can do 1-hour imaging. And if you notice any excessive blood pool uptake initially, to wait 3 hours and do the 3-hour image. There can be both false positives and false negatives of bone scintigraphy. This is important to realize that if you have a positive or negative test and your clinical suspicion for amyloidosis remains high, you may need to go on and do a biopsy. So some of the common causes of false positives are listed on the left. Commonly, AL amyloidosis, which we've already talked about you should have ruled out, can cause a weakly positive PYP or other bone scintigraphy. Another cause of false negative could be early disease. And if you do not make a definitive diagnosis with bone scintigraphy, you may need to go on and do a biopsy. This is often done when the patient has monoclonal protein or there's a discrepancy between the history and scintigraphy. And you can do a surrogate site, but often the target organ for cardiologists, the heart, has the highest yield. So on the left, you'll see that an endocardial biopsy can be stained with Congo red and will show positive images with Congo red staining, and it will also show staining with polarized light if there is amyloid present. Now, if you've confirmed that the patient does have amyloid in their biopsy specimen, it's very important to do protein typing. So typically we do mass spectrometry, and that will determine which specific protein is found in the biopsy. You can distinguish if it's light chain or transthyretin amyloid. This is a step people often skip, so you don't want to just do the Congo red staining. You want to actually go on and make sure you do protein typing. And if you've confirmed a diagnosis of transthyretin amyloidosis, then you want to go on and do genetic testing. So if the genetic testing is normal, the patient may have the wild type form of amyloidosis. Wild type means that the gene is in its normal or wild type form. And this is often seen in older patients. Or the patient may be found to have a genetic change, as Dr. Saraswat talked about, and that has autosomal dominant inheritance with incomplete penetrance. So you want to look to make sure that the patient either has an age-related form or due hereditary form because of the genetic implications for their family members. You never want to assume just because someone is old that you don't need to do genetic testing. And some mutations will present with a cardiac phenotype, some will present with a neurologic phenotype, but the majority of patients have a mixed phenotype, so it's important to get appropriate other specialists involved. And also to do cascade testing for first-degree family members.
All right, thank you both for this great overview. So if you tie it back to our patient, what you've heard so far is that our patient is not your typical amyloid patient that people ask you to think of, correct? As a younger woman who's presenting with neuropathy and cardiac disease, this is not screening. You're diagnosing the issue. And so that's where the problem is, that the patient presented with signs and symptoms, yet it wasn't necessarily discovered until later on. And keep that in mind. When we talk about screening, while you could say that I'm screening someone with heart failure, it is more or less you could have already diagnostic clues that tell you that you should be doing this, not just screen for it. And because she presented a while ago, this was before we had bone scintigraphy available to investigate patients, and so the patient had to have a heart biopsy to diagnose what is exactly going on. So those are some changes from the past that you have to think about. And so I'll try to move us along, but first we're going to stop and hear from our patient in regarding to the treatment.
In 2011, my symptoms became such that I needed to have a heart transplant. That was probably one of the most frightening days of my life, but also it just gave me so many answers. It finally answered the question, and I figured that I could potentially get well. So I did have a heart transplant in August 8, 2012. And since then, my heart has been fine. I had not experienced any problems with my heart. What did worsen over time, though, was the peripheral neuropathy, since there was no medication available to treat the neuropathy. In 2019, my neuropathy had worsened to the point where I qualified to be in a clinical trial for folks with polyneuropathy. Since then, the neuropathy has stabilized. In fact, I have improved. I was on the verge of not being able to walk a mile, not because of my heart, but because of the neuropathy. That has changed significantly. I am mobile, I'm up moving around, and I am really thankful and grateful for having something that has been very helpful to me to maintain my day-to-day activities and, in fact, be able to do things like travel and spend time with my grandchildren.
And this is part of the story why we're really lucky to be, taking care of patients nowadays, where we have therapies that can address the disease and prevent it from progressing. And so with these therapies, sometimes we still do in advanced patients, but in general, we can arrest the disease in its stage so that the patients don't require a transplant. Also, we can address the multisystemic symptoms, including neuropathy, that you really cannot address with a heart transplant, for example. And even back in the day with the liver transplant, you're not going to be addressing a lot of these symptoms as well. And so there are 3 approved therapies for transthyretin cardiomyopathy by the FDA: tafamidis, which is a stabilizer, and this is regardless if you have a gene-positive disease or not. You can be eligible for one of the 3. The other difference is that in vutrisiran, we'll talk about each of these, but with vutrisiran, it's also approved for nerve disease. So if you have someone with isolated nerve disease, also vutrisiran, they're eligible to receive that. Tafamidis and acoramidis are oral medications given daily. Tafamidis once a day, acoramidis twice a day, while vutrisiran is a subcutaneous injection once every 3 months by a healthcare provider. And so this is the mechanism of action of this group of medications called stabilizers. So what happens, as you've heard from our colleagues, is that the transthyretin protein gets secreted from the liver. It has to stay in its tetramer shape. And if it falls apart, that's a problem. And so you use a drug that binds to that tetramer shape and keep it stable like that. So what do you expect? The TTR level or prealbumin level will go up. So that's a natural response there. And you have tafamidis and acoramidis that stabilize the protein through different mechanism of action. So how do we know they work? Tafamidis was proven to work in cardiomyopathy through the ATTR study that showed improvement in mortality, heart failure, as well as function and feel of these patients. So we don't make patients feel better on average, but we do prevent them from progressing. And there are responders. There are some patients who feel better, some feel worse. But on average, your goal is to arrest the disease where it is. That's why it's so important to find out these patients early. Because if you can't make really sick people feel better, you want to find them early before they're sick. And so that's the key point here. With acoramidis, the trial name was Attribute, showing something similar where you have your improvement in your cardiovascular outcomes as well as improvement in feel and function of these patients when you're comparing it to placebo. Similar story, you want to find these patients early because you cannot improve necessarily all of them from baseline on average as well. Now, we do something different with that second group, second class, which is a silencer or knockdown agent class. So what we do here is that instead of chasing the protein and fixing that tetramer, preventing it from dissociating, you go after the liver as the source of the protein, and you reduce the translation of the protein. And so you inhibit that protein from being secreted into the circulation by about 80% on average. So you still have a little bit, but you inhibit the majority of it from coming out. And this is a very specific mechanism. You have 2 drugs that are siRNAs, but only one of them is approved for the cardiac disease, which is vutrisiran. And so vutrisiran is the subcutaneous injection we've spoken about that can be given once every 3 months and reduces the TTR level. So it gives you the opposite of that test that you've done. So tafamidis, acoramidis would increase the level of TTR if you check it, which is prealbumin, while vutrisiran would reduce that and even make it undetectable in certain patients. And how do we know it works in cardiac disease? It's based on the HELIOS-B study, where similar story, where there was reduction in cardiovascular events and mortality, as well as improvement in feel and function over time when compared to placebo. And so these are all important measures. It means that we have 3 options that we can work with the patient on and choose from, and there is no first, second, third line therapy, not really. We talk to the patient, we have a very comprehensive discussion about what's been shown, what are the characteristics of each drug, and then we have a shared decision making on selecting one of these agents. One of the differentiating factors about vutrisiran is that it's not a daily oral drug, but also is that it has been tested specifically and approved for neuropathy. So you can imagine if you have a patient who is coming to you because of heart failure and neuropathy, it is reasonable to consider and tell them that there is more neuropathy data in this space, and that's why, for example, I'm recommending this drug for you. So this is not a comparative Kaplan-Meier curve. This is a Kaplan-Meier curve that's just meant to show you that these trials have recruited patients over distinct periods. If you were here yesterday, Dr. Kettleson showed the same figure, showing that the tafamidis trial, which recruited more than 10 years ago, even more than 15 years ago, even the treatment arm had worse outcomes than the placebo arm in the more recent trials. So every trial, building on the subsequent trial, the patients have less disease. So you cannot do these cross comparisons between the trials because the patients at baseline are not the same. Why? Because of you. So thanks to all of you, thanks to all of the physicians and healthcare providers who are going after this disease, we are finding it earlier. So that's the key message. If you find it earlier, the outcomes improve so much more than historical. And so this is kind of the safety. People always ask, right, so you're giving a drug that keeps the protein around. So what happens if you take the protein away? Am I causing any problems? The answer is really no. We have now a lot of data on vutrisiran specifically, but if you take a step back on the overall silencer group, we have been doing this for 10 plus years now in neuropathy and close to 5 years already in cardiomyopathy as well. And you're not seeing anything out of the ordinary. So it is not necessarily unsafe to do this. However, no one is studying the effect on vitamin A since it's an easy intervention. When you do a silencer, you need to provide supplemental vitamin A with it by mouth. It can be given once a week, once every few days, depending on the recommended dose and how it's going to be taken. So something to remember. But we don't really have specific findings to suggest that this approach is not safe. And so this is another, this is another analysis of a drug that you haven't heard about yet, which is called eplontersen. Eplontersen is another silencer. The cardiac data will come out in the next, maybe later this year or early next year. But the data will come out about the cardiac disease specifically. These data are from the neuro trial. And so this is another drug that is available for the neuropathy indication, but you can't use it for an isolated cardiac disease. This only can be used in patients with nerve disease and is given once a month at home with an auto-injector as a subcutaneous injection, can be administered by the patient themselves or their caregiver as well. But we are awaiting the data for the cardiac trial, which enrolled 1,500 patients. And so, back to putting all of this together, again, if you've heard me speak before, I like to simplify stuff. Amyloidosis means that the patient has the disease in a solid organ, mainly for TTR is the heart or the nerves. If they don't have it in the heart or the nerves, you can't really treat these patients. It's observation. If they have it in the heart or the nerves, then you can treat these patients. And there is a very, very, very small number of patients who are way too advanced to be treated. I think that's beyond the discussion today. It is extremely small number of patients nowadays, thankfully, to us finding these patients a bit earlier and diagnosing them earlier. And so we talked about already the shared decision making, that we have to talk about which drug is best fit for the patient, and we'll talk about progression in the next few slides as well. And so this is where we're going to have a small discussion. We have 15 minutes, and we want to leave some time for Q&A as well. So I'm going to run quicker than planned through some of these slides, but we'll have a full discussion by the end of it. So we'll get back also to our patient.
Initially, when I was diagnosed, there were not coordinated teams to treat amyloidosis patients around the country. Now there are centers of excellence that include cardiologists, neurologists, nurse practitioners, there are occupational therapists, physical therapists, who are all aware of this disease and how it affects patients. And I actually have a team that does include a cardiologist, a neurologist, and I also have an occupational therapist and a physical therapist, and has developed a wellness plan for me so that I'm able to be as active as I possibly can be and enjoy my life. And that has been such an incredible improvement over the last 10 years. And I hope everyone who has this disease has access to the type of care that I do as a patient at this time.
And this is really an important summary, is that, while some of these patients, things are pretty straightforward, you find someone who has LVH, some heart failure symptoms, you don't have AL labs positive, the PYP is positive, and it's pretty straightforward, and you can just use a medication to treat them. But in general, about 10 to 15% of the patients are complex and complicated, and as such, having a multidisciplinary team guarantees that people don't make mistakes. And so we can share so many cases with you that things were not as easy as they seem to be. That's where I think this is important. The second point to remember is that when we put someone on a medication and they come back to us a year later saying that I feel worse, you have to differentiate two things. There is the amyloid part of it, which is infiltrating the heart over the years, that led to the heart failure syndrome. So patients can actually progress with their heart failure without necessarily progressing with their underlying amyloid. So your medications actually could be doing their work, but you don't reverse the heart failure story. So what you need to do, make sure there are no other factors that precipitated the worsening of heart failure, and make sure you understand and separate why is the patient feeling worse. There are many domains that we can test how the patient is feeling, some biomarkers. Imaging is so-and-so. I wouldn't necessarily recommend that we rely mainly on imaging to talk about progression, but more or less other stuff, functional assessments, quality of life symptoms. I think this is really important to think of. And so recognizing is more important than anything else. Is that if the patient keeps coming back, they need more diuretics, they got admitted to the hospital, they're feeling worse, these are the things that you should think about. What is going on there? Because that can help you and help the patient, again, achieve better care, but also not miss stuff. Because these patients don't live in isolation. Someone coming to you with worsening symptoms, they actually could have coronary artery disease. And this is a true story from 3 months ago. Someone is feeling terrible being on treatment for a long time. And I'm like, doesn't make any sense. Why you're feeling terrible now? And we just found them to have left main disease through the workup. So if you just assume it's amyloid, you're going to say, okay, let me try you on a different medication, but that's not going to fix the issue. And we've published on this before in collaborations with others that you can use significant worsening of NT-proBNP, not just dead cells of worsening, no, significant worsening of NT-proBNP, or continuous increase in the use of oral diuretics as an outpatient as measures of worsening disease as well. And atrial fibrillation is very, very common. If patients develop AFib and they're worse, you should treat that. Some patients develop AFib and they're not worse, so you can maybe think about leaving them be. But the most important piece here is that you shouldn't apply the CHA2DS2-VASc risk score for these patients. You should anticoagulate them no matter what. You shouldn't apply the CHA2DS2-VASc risk score. Anyone with significant structural heart disease like amyloidosis, like HCM, like Fabry disease, these kinds of diseases, you don't use CHA2DS2-VASc risk score and you just anticoagulate them. And in terms of managing the progression, I think the most important piece, make sure that the patient is actually taking their medication and they don't have any objections about that. Make sure that there are no drug interactions that you're essentially encountering. Make sure there are no other factors that are precipitating what is going on with these patients and why they're feeling worse. And then think about, involving other colleagues. Think about, people who can help with physical therapy as well as occupational therapy as well. And so this is where all of these centers with many, many different domains of individuals who are involved can be really, really useful. I would say that this is a lot more important early on in the process of diagnosing patients and making sure they're on the right track. It becomes less vital that every visit you involve everyone. It becomes easier over time, but the initial portion of it, I think it's really important to understand exactly what's going on with the patient. And there are many, many benefits to having interprofessional care team, better outcomes for the patients, but really I think recognition and making sure you're not making mistakes, diagnostic mistakes, I think are the most important pieces there. And access to therapies as well as to gene testing are always an issue. There are free sponsored gene testing programs for TTR. Keep an eye on those, and you can do them in your own clinic for free. As well as there have been some changes in access to therapies that made it easier for us to get these therapies to our patients. So I think this is becoming a much, much less of a problem compared to 5 years ago, for example. All right, I'll skip the key takeaways because we want to get to some of the questions here that you already sent us, and thanks to the online audience as well for sending us some questions. We'll try to do this kind of almost, a little bit a rapid fire. We have 9 minutes, so we have some time to talk about things. If you work in a family medicine practice, how do you think about this, and what labs would you order to make sure that the patient doesn't necessarily have a condition like this?
If I worked in a family medicine practice, the first thing would be that I would look for systemic symptoms. So anybody that has neuropathy and cardiomyopathy, I would maybe think about amyloid, maybe also some soft tissue manifestations. And the things I would start with would just be to do the light chains and the immunofixation, serum and urine, and then an echo with strain, if you're able to do that, and biomarkers. And I think that's a good start, and then you can always refer to cardiology for the rest.
Great. And there is another thing to remember in a family medicine practice, in a primary care practice. If someone is coming to you short of breath, NT-proBNP, you're going to check CBC and liver and kidney and all that stuff routinely because you want to work them up. But remember, NT-proBNP actually can be a good friend. In someone who's not congested in front of you, huffing and puffing, having an elevated NT-proBNP that is discrepant from the degree of their symptoms is actually a pretty good clue. So that's something to think about.
I'll just add, if family medicine or internal medicine physicians here, the fact, if you're able to even think about this and have that high index of suspicion, you've already done the patient a service here, right? The fact that you're even thinking about the different manifestations and putting those things together, you can always get an amyloid specialist to go through the echo and look at the strain and all of these things, but just amazing that to even connect those dots, you've already knocked it out of the park already at that point.
Completely agree.
Yeah. Great point, which goes back to something we said yesterday, is that you can set your practice as trying to explain left ventricular hypertrophy. If you see it in a report, for example, on an echo, you don't have to really worry too much about the specific exact diagnosis up front. But if you set your mind that if someone has significant left ventricular hypertrophy, why do they have it? It's the same thing as having low ejection fraction. Why do they have it? If you get there, I think that's most of the work already. We have another question. If a patient has slight elevation in their kappa-free light chain, and you think they have a small MGUS, for example, but they do have heart failure and they're refusing an MRI due to claustrophobia, how do you approach this diagnosis yourself? So someone with heart failure, a tiny MGUS, and you want to work them up, but you can't do an MRI, what would you do?
Can answer.
No.
Certainly I go back to their initial echo, potentially do strain on the echo, review it with the imaging person if I'm not the person reading it, and look for signs on there. And then a lot of it is really that multidisciplinary discussion, right? Is it a small amount? How much gammopathy is there? And then it's a discussion about whether or not a cardiac biopsy is necessary. That's the key thing, to not be scared of the idea that potentially a biopsy is where you have to go. For me, as a heart failure transplant doctor, we're doing biopsies all day long. I think if you're in a center or you're comfortable in referring to a center that's doing frequent cardiac biopsies, the risk of a cardiac biopsy of perforation is less than 1%, right? And then particularly if it's a patient who has significant LVH, that incidence of complication goes down even further based on where we're biopsying. So to have a definitive diagnosis, to make sure that you're treating the patient for the right disease is paramount. And I think don't be afraid to bring up the idea that you might need a biopsy.
And I would say don't be afraid to talk to a hematologist. Sometimes cardiologists are nervous about asking dumb questions, about interpreting those light chains, but it's always fine to ask for help from a hematologist. You can ask your colleague, don't be afraid to do a biopsy, but also it's okay to ask for help to interpret those.
Yeah, and there's a lot of details that we didn't cover today, but we're looking for a monoclonal issue, not a biclonal issue. If everything is up, it's not the same, so you can talk to hematology about that. The other thing is that there are specific cutoffs for GFR, for kappa levels. So look at the specific GFR cutoffs for the kappa levels for specific GFR cutoffs, because you could have a slight kappa elevation that is normal as well. So there's a lot of details that we didn't cover today, but just keep in mind that you need to talk to others if you're not familiar with these settings. I'll take this question myself. If you're in doubt with a PYP, but you still have index of suspicion, would you do MRI or you go for a biopsy? So the important piece here is what do you have access to soon? Because if they have, for example, suspicion of light chain with a borderline PYP, for example, or whatever, you don't want to really be waiting 6 months to get an MRI. If you can get an MRI in 1 to 2 weeks, that's fine. If the MRI needs 3 months, but you can get a biopsy in 2 weeks and they have heart failure, go for the biopsy. If they are asymptomatic, totally asymptomatic, wait for the MRI. But also if the PYP is equivocal or whatnot, the MRI is not going to be also slam dunk a lot of the times. So it might just be a combination of the above and not just one or the other. But the biggest mistake that I see happening in practice is that people misinterpret the labs. They think that the patient doesn't have, for example, light chain amyloidosis, or they never got in those labs to begin with. The PYP is equivocal or whatever, borderline, and then they wait 3-4 months for the MRI, and during this time, the patient is actually worsening with their underlying disease. That's what we don't want. All right, we have 3 minutes. We'll take this question, and I would like to hear from both of you, since this is the most difficult question that always comes up. What do you think about combination therapy using both silencer and stabilizer at the same time, and what's your practice?
I think this is a challenging question that, as you said, comes up every day. Right now, I think the evidence that we have for combination therapy is really not very strong. I certainly have patients that are on combination therapy, and it's because they're from the era of prior to vutrisiran FDA approval for cardiomyopathy, right? So there are patients that had hereditary polyneuropathy, were put on a silencer, and were on a stabilizer for cardiomyopathy when we didn't really know. In the last, I guess it's been since March of 2025, since vutrisiran was approved, these are the discussions we're having. Certainly, I don't intentionally put people on dual therapy if they're already on. There are patients that I'm taking away a therapy, which in some cases is more challenging than not adding, right? And a lot of patients will get nervous at the idea that they're doing well. Why would you take one of these medications away? And I think the other challenge is that we're still learning, right? As Ahmad mentioned, we're waiting for the results of cardio-TTR transform, which may give us some more of these answers. I may have very different data 6 months from now than I do now. So how do you take a medication away knowing that in 6 months that I may have a different answer? So, I think we're lucky in a way that the amyloid community and these patients are very invested in their care, very invested in the data. And often as I have these discussions with them, we work through the data together and talk risk-benefit about what's appropriate for them as a person and their family, and say, hey, we'll keep addressing this every time we talk.
Great. Noel?
I agree with everything Dr. Saraswat said. They're complicated decisions. I think it's most important patients are on a therapy. For patients with neuropathy, I typically lean towards a silencer. In some patients where it's feasible, I do have patients on dual therapy, but I think it's becoming more and more difficult to do that. And the reason, as Dr. Saraswat said, was previously because we had a lot of patients in trials and unclear what worked for what, we were able to do a lot of multiple therapies, and it's becoming more difficult. But just getting someone on therapy is the most important thing to me.
Definitely, I fully agree. And then if you refer to the ACC, it's a consensus statement. It's not like it's evidence-based necessarily in terms of this, but there is a huge lack of evidence for combination therapy. And as such, the ACC consensus statement or pathway statement, Dr. Ketelsen led and put up yesterday as well, that you should not be doing combination therapy for the majority of the patients you have. Rather, you can pick and choose between the three options we've discussed. You can switch between them, you can move things around, but it's preferable that you don't approach this from a combination therapy perspective because you might be giving a drug for no reason, and none of us want to do that. With that, I want to thank you both. I want to thank our audience here and online for being with us today, and enjoy the rest of your day. Thank you.